Hello, everyone, and welcome to another episode of Arthritis at Home. My name is Ellen. I am the Programs Coordinator. And today we are joined by Dr. Lihi Eder, who is a clinician scientist at Women's College Research Institute and an Associate Professor of Medicine at the University of Toronto. Welcome, Dr. Eder.
Hi, Ellen. It's nice to be here.
Dr. Eder, can you remind us about how you're involved in rheumatology? And we know that you've been on episodes previously of Arthritis at Home, but share a little bit with us again about your work.
Okay, so my main area of interest is psoriatic arthritis. And today I'm not going to talk about psoriatic arthritis. I'm going to talk about spondyloarthritis, which is a very related condition. But more recently, my research has focused on sex and gender issues in arthritis in general and trying to understand why men and women with arthritis respond differently to medications. So this is the topic of our episode today.
Thank you for that, Dr. Eder. And I do want to congratulate you on the Canadian Research Chair of Inflammatory Rheumatic Diseases for exactly this, studying the differences in sex and gender as determinants of disease outcomes. So let's start with this kind of not new area of study, but new for us because we're just learning about it. What is, as we call it in research, AxSpa or axial spondylitis, and who does it affect?
Okay, so it's not the usual SPA when we think about SPA. This is an acronym for spondyloarthritis, and the ax mean axial, so axial spondyloarthritis. And so this is a condition that encompasses or includes a wide spectrum of diseases that some of them used to be called ankylosing spondylitis in the past, and it also includes and broadened to include maybe a milder forms of spondyloarthritis. And basically, spondyloarthritis means that the arthritis affects the spine. And so the inflammation in the spine and the joints there can cause pain, it can cause stiffness, and if untreated, it can cause bony bridges that eventually forms this very stiff spine and lead to limited range of motion. So AxSpa could include ankylosing spondylitis, which is the more severe form, and this is where we can see the damage already in X-rays, but it can also include milder forms that are not seen in X-rays, and they are called non-radiographic AxSpa. And so when we talk about these two conditions, radiographic and non-radiographic, the radiographic, the more severe form, ankylosing spondylitis, is a male predominant disease. It affects more males, 3 times more than females, while non-radiographic axial SPA is affecting males and females equally. And overall, if we look at the Canadian population, between 1 in 500 to 1 in 1,000 adults will be affected by axial spondyloarthritis.
Most definitely not a rare condition, and most definitely, when we think about the presentation of rheumatic diseases, usually, and I use that very broadly, women are more often affected than men, or females are more often affected than males. But this is very interesting that in this case, the severe form, the radiographic form of really, it's a family of spine affecting arthritis affect males more commonly.
I should say when I mention more severe, I really mean only the radiographic, the way it appears in the spine, because the burden of disease, when we think about symptoms, pain, disability, they are actually equal and sometimes even more severe in female patients, even though the condition may be more common in males. So even though, so severity is something that we need to kind of, it can be viewed in different ways, not just the X-rays, but also how it affects the individual living with this disease.
Well said, absolutely. And or more recently, you presented at the EULAR 2024 conference, and you presented a literature review which looks at, all of the studies to date, perhaps, or, quite a few of the studies that have been published on the sex-related differences in study outcomes for this condition. Will you share, perhaps why this is an important topic and why it's important for us to discuss and learn about?
Yeah, so the reason we conducted these studies that we know from observational studies, so these are studies that people have done in clinics and not necessarily related to treatment, that male and female patients with axial SPA present differently. And as I mentioned before, male patients tend to develop the more severe bony bridges, the damage that we can see in X-rays. But female patients, despite the fact that we see less damage, they tend to have more pain, they tend to have more fatigue, they are more likely to discontinue working because of this condition. And they also respond less well to treatments. We don't know why this is. But despite all of this research, there is very little data from randomized controlled clinical trials, meaning that randomized controlled trials are really the optimal way, the best way of assessing whether a medication works or not, because it really randomly assigns people to a placebo or to the drug, and it avoids different types of biases that can happen when we just observe people. So this is the perfect study design. But surprisingly, no one has looked at the differences in males and females in these randomized controlled trials. So we decided in this study that we wanted to compare the effect of the biologic treatment. So biologics are medications that are approved and are very considered to be effective for AxSpa. There are currently several classes of biologics, and there are TNF inhibitors, IL-17 inhibitors, and JAK inhibitors that are approved, and each class affects different part of the immune system. So we wanted to see whether males and females respond differently to these drugs. These are very effective, but also costly drugs, and currently there is no way for us rheumatologists to know which medication works best for which individual. It's possible that because males and females respond differently, one drug might be more effective in males or in females, or it is really critical to understand how males and females respond. So basically, this study aims to systematically evaluate all the trials that were published to date and compare the response in males and females to better understand the differences.
And systematic review is a huge undertaking because you are coming in with a specific, research question. Then you search all of these databases, so you're casting a net. And then the ones that don't, in this case, you were looking specifically at randomized control trials. Ones that do not fit your criteria, they're excluded. And then you're left with a pool of randomized control trials. But that's not the end. You guys went one step further to meta-analyze all of these studies. And that is just a fancy way of saying that, each study has its own results. But is there a way to look at all of the results together? And we say pooling in research. But Dr. Eder, could you, please share with the audience a little bit more about, the statistical techniques used to what we call meta-analyze these randomized control trials?
Yeah, so Ellen, you kind of explained it very nicely. I mean, just to give you first, before we go to the meta-analysis, the systematic literature review was huge. So we reviewed over 6,000 records, 3 large databases. We also took one step further and looked at FDA databases, because sometimes the results that are reported by sex are not reported in the medical literature, but they are actually part of the application packages that each company submit to the FDA. So they are available. It's just very difficult to find them. So we identified a total of 79 randomized controlled clinical trials out of over 6,000 records. Basically, the meta-analysis method, as you mentioned, allowed us to combine results from different studies. So we kind of don't have the database itself, but we have the results of how males responded, how females responded, and then using regression models, and there are specific ways of mathematically combining these across different trials and coming up with an effect size. So how much males are more likely to respond to drug or a class of medications than females. So we look at it by classes of medications. So we assume that there are not much differences between the different TNF inhibitors. We know that there are different TNF inhibitors that are approved. So we combined all of them together. We combined all of the IL-17 inhibitors together. Unfortunately, we didn't have any data on the JAK inhibitors, which are the newest class of medications. So we were able to come up with these two separate effect sizes for the classes of how males are more likely to respond than females, basically. I think these were the main results of the study, basically.
And I will emphasize what a huge undertaking, 79 studies. It is a lot of math, and it is a lot of checking your work, and it is a lot, but very, very interesting to be able to do that with research. Dr. Eder, can I ask what you've learned from this project thus far, and how will these results influence patient care?
So there are several key findings, and before I get to the differences between males and females, I just wanted to highlight the fact that only a minority of these 79 trials actually reported the results by sex. So we were not able to include all of these 79s because the results were just reported as males and females together. So in total, we could only include about a quarter of these trials in the analysis, and that's a major limitation, but it's also something that we wanted to highlight for the future, that journals and pharmaceutical companies in the future hopefully will consider this to be important to report the results by sex, to allow us to do more meta-analysis with newer medications. So when we look at the results, there are several differences. One is the differences in males and females when they start the study. So there are differences in characteristics. Female patients tend to be older. They tend to have higher BMI, so obesity is more common. They also tend to report higher level of disease activity. So BASDA is a questionnaire that is used to assess disease activity, how much pain, how much stiffness, how much fatigue there is. So female patients tend to report higher levels there. Male patients, interestingly, had higher levels of CRP, which is an inflammatory marker. So there are some differences there that might explain some of the differences in response to treatment. Now, when we look at response to treatment, we see that male patients have 80% higher chances of achieving response compared to female patients. And that was seen across different classes of medications and when combining all of these medications together. So both among TNF inhibitors and among IL-17 inhibitors, we see similar preferential response in males than in females, which means that basically both drugs work better for males. The other interesting finding was that there were less differences between males and females when we look at the more severe form of axial SpA. In the radiographic axial SpA or ankylosing spondylitis, there is less differences between males and females, and the differences are a lot more pronounced in the non-radiographic AxSpa group. So what does it mean? I think first we do highlight the fact that there are significant differences in males and females. Females are less likely to respond to biologic medications, to both IL-17 and TNF inhibitors. So which means that at least for these two drugs, there is no I mean, there is no point in selecting one of these classes based on the sex of the patient. It also means that physicians should pay more attention to female patients, maybe see them more frequently, consider pain and management of pain as an important component of treatment. It also raises questions about what mechanisms are driving these differences. We think that differences in pain perception, maybe differences in the immune mechanisms of these medications, maybe differences in what is called pharmacokinetics of drugs, is basically how the medication is distributed in the body of males and females are different. There are lots of potential mechanisms, but unfortunately, with this type of study, we cannot really investigate it because we only have the aggregated results. And this study and other studies that we've previously published in psoriatic arthritis are driving us to conduct dedicated studies to understand why males and females are responding differently. And once we understand the mechanisms, I think it would be really important for informing care, for more personalized care of patients living with these conditions. So more research is needed.
More research is needed, but what sometimes the best thing that comes out of research is we start asking better questions. And I am just so fascinated by these results because, number one, you were only able to capture male and female in a quarter of the studies, meaning that 3/4 of studies did not report by sex the different outcomes. Another one of my thoughts was, it's very interesting how the two classes of biologics in this case showed preference for, say, better treatment outcomes. And these are clinically, for everyone listening, these are clinically different, not just statistically, these are clinically relevant outcomes in this case for males. But once we have the data on JAK inhibitors, it'd be very interesting to see if they follow this pattern, because then we have to ask ourselves, what is happening? It's really is just so fascinating. And like you said, there is this movement towards tailored care, and this is the information that clinicians need to really understand how to tailor care more for their patients. So I think it's a huge step, and so many interesting questions have come out of this. And Dr. Eder, I'm just so excited to see what is your next step from here.
Well, I actually am working right now on a grant application to analyze more. We actually were able to get access to the actual data from some of these trials, and that will allow us to look at some of these mechanisms. For example, if higher levels of the drug in the body actually exist in males, and therefore maybe that's the reason they respond better. Is it differences in pain perception that is explaining this? So getting access to the granular data will allow us to investigate and explore some of these potential mechanisms and understand these better.
We look forward to learning about these mechanisms. In that case, Dr. Eder, thank you so much for your time. Thank you for teaching all of us about in this case, sex differences between not only the severity, but also the clinical manifestations and the relevance of this work to all of us. It's great for patients to know as well, if you are somebody living with axial spondylitis, to really advocate for yourself. If you are, in this case, female, and something like a biologic doesn't seem to be working super well for you, there's a reason for that in this case, and to take that information, and it is power in this case. Information is power. So thank you so much for your time, Dr. Eder.
Thank you, Ellen.
Well, hope everyone joined us for another episode of Arthritis at Home. And with that, we hope you take care and have a great rest of your week.